Welcome to Section 5 in Neurology. In this section, we will be discussing the cerebellum. So let's get started. So first, we're going to go over the cerebellar anatomy really quick. And the main thing you need to know is that there are hemispheres, there's the vermis, and the flocculonodular lobes. And the hemispheres are primarily responsible for the limbs, so the lateral corticospinal tract. And if damaged, it can cause limb ataxia, intention tremor, dysmetria, and dysdiadochokinesia. And we'll explain what these look like. Now, the vermis can be called the spinocerebellum, and this interacts with the axial muscles, so the anterior corticospinal tract. If you damage this, you can get truncal ataxia, or ataxia while walking, gait ataxia. Now, the flocculonodular lobes can be called the vestibular cerebellum, and it's involved with eye movements. And if damaged, you can get truncal ataxia, just like with a vermis damage, and you can also get nystagmus. So here's figure 8.26 from your text. On the right is a mid-sagittal view of the cerebellum. Now, the right side of the image is anterior and the left side of the image is posterior. If we took a coronal cut of this right image, we would get the image on the left. Now, the top of the left image is superior and the bottom is inferior. So looking at the left image, we can see that the middle portion is the vermis. And as mentioned in the previous slide, if this is lesioned, the patient will demonstrate truncal ataxia or gait ataxia. So the patient will appear uncoordinated while walking. On the outside, we have the hemispheres, which you can see labeled on both images. Now, if you lesion the lateral hemispheres, then you will get ipsilateral limb ataxia. Symptoms of limb ataxia include dysmetria, dysdiadochokinesia, and intention tremor. And we will discuss these symptoms and what they look like more on the next slide. Now, on the bottom, we can see the flocculonodular lobe, and this is involved in eye movements. So if this is lesioned, the patient will demonstrate nystagmus, or repetitive, uncontrolled eye movements. So this is a general overview of the cerebellum. So if you remember what has been described here, you will correctly answer almost all of the cerebellum questions you will get for step 1. There is a little bit more information you need to know, however, so let's quickly go over that. So this is a review of the cerebellar anatomy. So now let's review what these lesions will look like. So if you damage the hemisphere, you get hemisphere lesions. Once again, you'll get limb ataxia. Recall that you'll get intention tremor, dysmetria, or dysdiadochokinesia. Now, intention tremor is trembling when making a movement. And remember, it's going to be on the ipsilateral side. So if the patient damages the right cerebellar hemisphere, then the right arm or right leg will demonstrate trembling when that patient is trying to move those limbs. Now, dysmetria is undershooting or overshooting with a finger. And this can be tested when a clinician asks a patient to touch his or her finger with the patient's own finger. And sometimes they'll overshoot it or undershoot it, and this is called dysmetria. Now, dysdiadochokinesia means that the patient cannot perform rapid alternating movements. So in clinic, patients can be asked to flip their hands on their lap over and over and over again so that their palms face up and then down, and do it really quickly. And if they have a hemisphere lesion, then they could demonstrate dysdiadochokinesia and will be unable to do it with that limb. So now talking about vermis lesions, so in the center, or the midline of the cerebellum. If you damage this, you'll get truncal ataxia, so that's a lack of coordination while walking. This can be gait ataxia as well. This is a general overview of truncal ataxia. There can be other symptoms, for example, while the patient's sitting, and they have a hard time maintaining posture because of truncal ataxia. But for the most part, you're going to see it with gait. They're going to have trouble walking. And flocculonodular lesions will cause truncal ataxia, just like we mentioned with the vermis lesions, and will result in gait ataxia. But it will also result in nystagmus, which is those repetitive, uncontrolled eye movements. So now let's talk about the layers and the fibers of the cerebellum. We have the white matter in the center, and then there's the molecular layer, the granule layer, and the Purkinje layer. So let's draw this out. So this is figure 8.27 from your text. In the middle is the white matter, which we have labeled. So to put this simply, a signal will travel into the cerebellum through the white matter. If the cerebellum is to send information out in order to modulate movement, then the Purkinje cells in this layer here will be stimulated. So you can see that right there. And these Purkinje neurons, if they are to send a signal out of the cerebellum, will send their signal to the deep nuclei of the cerebellum. Before we talk about these deep nuclei, just remember that the Purkinje neurons are the only output of the cerebellar cortex. Now granted, this is a little simplistic and the cerebellum is a little bit more complex than that. However, for step 1 purposes, just think that the output from the cerebellum is through these Purkinje neurons. So now let's talk about these deep cerebellar nuclei. There's the dentate nucleus, which is the most lateral one, and there's the embelliform, globose, and the fastigial. Now each nuclei corresponds to a specific location of the cerebellum, and all receive an inhibitory input from the Purkinje neurons, which, as we recall, is the output of the cerebellar cortex. It's best to imagine that, by default, these deep nuclei are sending off signals. When the Purkinje neurons release GABA, the deep nuclei will be inhibited. This allows the cerebellum to modulate movement as necessary. And then these nuclei, once stimulated, or rather inhibited by GABA, they will all send axons out of the cerebellum via the peduncles. Now to remember these nuclei, some people like to say, don't eat greasy foods. So dentate, embelliform, globose, and fastigial, from lateral to medial. Personally, I like degrees Fahrenheit, just easier for me to remember. So remember, lateral and fastigial is the most medial. This is figure 8.28 from your text, which shows a transverse section of the cerebellum and the deep nuclei. Now from the most lateral, we have the dentate, so this is the don't, and then we have the embelliform nucleus, and on the right half we can see it right here, so E for embelliform, and then we have the globose, which you can see right here, G for globose, and then we have the fastigial nucleus. So don't eat greasy foods, or simply degrees Fahrenheit. So you don't need to be able to identify all 4 of these nuclei. In fact, the only one that you should really be able to identify grossly is the dentate nucleus. As you can see, it's very large. The takeaway is that the Purkinje neurons will send axons to these nuclei and release GABA. And this is an inhibitory neurotransmitter, and it will inhibit these nuclei. And these nuclei will then send out axons through the peduncles, which we will talk about next. So if we put figures 8.27 and 8.28 side by side, we can see that a signal from the Purkinje cell will then go to the deep nuclei, where GABA is released, and then the nuclei will then send the signal out the peduncles. So now let's talk about these signals that exit the peduncles. Now starting with the superior peduncle, this will send proprioceptive information out to the contralateral VL of the thalamus, VL standing for ventrolateral nucleus. Now after reaching this point, the VL will then send projections to the motor cortex. Now the middle peduncle will send intention information in from the contralateral cerebral motor cortex. In other words, the cerebral motor cortex will send information to the cerebellum about what movements are about to take place in the body. So intention. Finally, the inferior peduncle will receive proprioceptive information in from the spinal cord. So here is figure 8.29 from your text. This shows the 3 pathways for the cerebellum that you will need to be familiar with. So let's start with this blue line. Recall from section 2 that the motor cortex, via the corticospinal tract, will send fibers down and initiate movement. Now while the motor cortex innervates the muscles, it will also send motor information to the cerebellum, as if to tell the cerebellum what the motor cortex is intending to do. This can be called intention information. So we can erase this corticospinal tract line, and we'll just focus on this cerebellar pathway. So the motor cortex will send intention information to the cerebellum, and this is via the corticopontocerebellar tract. Now meanwhile, the muscles are moving, because recall that the motor cortex actually innervated the muscles. So there's going to be proprioceptive information that will be sent back to the cerebellum. This is what you can see with this green line. This is proprioceptive information, which, as you can see in the key on the right, this is the spinocerebellar tract. Now recall that the dorsal column is what carries the proprioceptive information. So the dorsal column carries the spinocerebellar tract. Now this information will tell the cerebellum where the body is and how the movement is going. You may recall from section 2, where we discussed the dorsal column medial lemniscus pathway, that the proprioceptive information will decussate at the medulla. So as the proprioceptive information is carried up through the dorsal column, it will decussate at the medulla, and it will cross the midline. This is not the case with the spinocerebellar tract, so we'll erase that. For this tract, think of it as staying ipsilateral and never crossing the midline. As you can see clearly here, it does not cross the midline. Technically, there are two parts of the spinocerebellar pathway, and one does cross the midline, like this, but it crosses back, so it eventually ends up on the ipsilateral side. So the point is that you can always think of the spinocerebellar tract as staying ipsilateral. So to summarize, the motor cortex innervated a muscle causing movement. The motor cortex also told the cerebellum the intention, and then the cerebellum received information via the spinocerebellar tract and carried the proprioceptive information to see how the movement is actually going. So now the cerebellum has the information about what should be happening and what is actually happening. This brings us to the red line, the cerebellothalamic tract. Now this is where the cerebellum will send information to the ventral lateral nucleus of the thalamus, which will then go to the motor cortex. Now the motor cortex can then fine-tune its movements, leading to even greater precision because of the information that the cerebellum provided. Now a way I like to remember the function of each one of these tracts is to look at their names. The spinocerebellar tract goes from the spine to the cerebellum, in that order. The corticopontocerebellar goes from the motor cortex to the pons, then to the cerebellum, in that order. Now don't worry about the pons in this tract. It's enough to know that this tract goes through the pons before reaching the cerebellum. Now the cerebellothalamic tract goes from the cerebellum to the thalamus, in that order. And of course, if it goes to the VL of the thalamus, the VL will then innervate the motor cortex. Now why is this relevant? Well, first, know that this is the left side over here because we are looking at the dorsal aspect of the brainstem. And if you damage this left side of the cerebellum, then the right motor cortex, which is up here, which is trying to innervate this left side of the body, will be all messed up. So the patient will develop ipsilateral or left-sided limb ataxia. And ipsilateral ataxia includes intention tremor, dysdiadochokinesia, or dysmetria, which we discussed earlier. So just remember that cerebellar damage will cause ipsilateral signs. Now one thing that you also need to know is the peduncles that are used. Now the spinocerebellar tract uses the inferior peduncle, which we have labeled on the right side. We'll fill that in with green right here. The corticopontocerebellar tract will use the middle cerebellar peduncle, which you can see, this large one. We'll fill that in with blue. And then finally, the cerebellothalamic tract will use the superior cerebellar peduncle to send information up to the motor cortex. So just as a review, the incoming tracts, the spinocerebellar and the corticopontocerebellar tracts, will enter through the white matter, and then the Purkinje neuron will be stimulated. Then it will send fibers to the deep nuclei, and these deep nuclei will then be stimulated to send their information through the cerebellothalamic tract, through the superior cerebellar peduncle. Now the cerebellum can become much more complex than this if you want it to be complex. However, for step one, these are pretty much all the facts you need to know. Now let's do some questions to apply this knowledge. During a neurologic exam, a patient is unable to touch the clinician's finger with his own right finger. However, he is able to touch the clinician's finger with his own left finger. A CT scan reveals a tumor in the cerebellum. Where in the cerebellum would you expect to find the tumor? So this patient is unable to touch the clinician's finger with his own finger. This is a classic representation of dysmetria, which we discussed earlier in this lecture. The patient demonstrates dysmetria on the right side, but not the left side. Due to this clinical symptom, dysmetria, we are thinking of a cerebellar lesion. The CT scan shows a tumor in the cerebellum, so where do we expect this tumor to be? Well, dysmetria is a sign of a hemisphere lesion, so we suspect the right cerebellar hemisphere. Now this may seem pretty straightforward and simple. The patient has right-sided cerebellar symptoms, so we suspect the right cerebellar hemisphere is damaged. But this is exactly how you'll be tested on step one. The cerebellum is very straightforward, don't overcomplicate it. Now let's do one more question. Now a patient seems to have uncoordinated movements while walking. If cerebellar damage is the cause of this presentation, where is the damage likely to be? Now this presentation is describing gait ataxia or truncal ataxia. So where in the cerebellum is there likely to be damage? Well, gait or truncal ataxia makes us think that it could be the vermis or the floccular nodular lobe. These both can result in gait or truncal ataxia. Now, without more information, you can't really know which of these two it is. However, if I told you that on clinical exam the patient has no nystagmus, you would then no longer suspect the floccular nodular lobe. Instead, you would just think it's the vermis. So now let's review the peduncles. The superior peduncle will send proprioceptive information out to the contralateral VL of the thalamus. And from that VL, it will send information to the motor cortex. And this is called the cerebellothalamic tract because it goes from the cerebellum to the thalamus and then finally the motor cortex. Next, we have the middle peduncle, which starts in the motor cortex of the cerebrum and sends intention information in from the contralateral cerebral motor cortex. And this is called the corticopontocerebellar tract because it goes from the cortex through the pons and then ends up in the cerebellum. Lastly, we have the inferior peduncle, and this will take proprioceptive information in from the spinal cord. So this is called the spinocerebellar tract. So spine and cerebellum. So now let's quickly talk about the vestibulocerebellar tract. And as it sounds, you got the vestibulo, so vestibular nuclei are involved. Then you have the floccular nodular lobe, which is a part of the cerebellum. So what happens is it goes from the vestibular nuclei to the floccular nodular lobe, and then it goes back to the vestibular nuclei. And then from that point, it goes to the cranial nerve 6, which is the abducens nerve. Now remember that the abducens nerve will innervate the lateral rectus muscle of the eye. And this whole pathway going from the vestibular nuclei to the floccular nodular lobe and then back to the vestibular nuclei and then to the cranial nerve 6 and then finally the lateral rectus muscle, it all remains ipsilateral. It's all ipsilateral, which means that cerebellum is really, really simple. Just remember ipsilateral. Now if you damage the vestibulocerebellar tract, you're going to get truncal ataxia, which we discussed previously, and you also get nystagmus due to this lateral rectus muscle stimulation. Here is figure 8.30 from your text, and it shows the relevance of the floccular nodular lobe of the cerebellum, which is right there. Now as you can see, the floccular nodular lobe will send signals to the vestibular nuclei, which you can see with these red fibers. The vestibular nuclei will then send signals back to the floccular nodular lobe, which we can see with this blue line. The point is that the cerebellum can interact with the vestibular nuclei, which then stimulate the cranial nerve 6, which then stimulates the lateral rectus muscle. So if you lesion the floccular nodular lobe, then this pathway will get disturbed, and then there will be nystagmus of the eye, in this case, the right eye. Also keep in mind that the floccular nodular lobe, much like the vermis, can cause truncal or gait ataxia, which we discussed earlier in this lecture. So if a patient presents with gait ataxia, and you're trying to distinguish between a lesion in the vermis versus the floccular nodular lobe, then you can just look at the eyes to see if the patient demonstrates nystagmus. If so, you're more inclined to think that the floccular nodular lobe has been lesioned and not the vermis. Now let's briefly talk about how to dominate cerebellum questions on step 1. So first, remember that if the hemisphere is lesioned, this will cause limb ataxia. There's 3 things you need to remember about limb ataxia. That's intention tremor, dysmetria, and dysdiadochokinesia. And always remember that the symptoms are ipsilateral. If you damage the right hemisphere of the cerebellum, you'll get right limb ataxia. Also remember that the vermis causes gait and truncal ataxia if lesioned. And then recall that the floccular nodular lobes, when lesioned, will cause gait or truncal ataxia and nystagmus. Nystagmus being how you can distinguish clinically from a vermis lesion. And that concludes this section.